it. In regards to the imaging, we definitely get x-rays, and certainly x-rays in general for joint evaluation, or whether it's be an injury or just symptomatic pain is first line. And in this case, it definitely would be the first line as well, because x-rays will really give you a really good view of the anatomy and the outline, potentially of the OCD defect. In particular, if it's in the knee, if we're talking about the knee, the standard kind of views that we get, for knee x-rays would be a weight-bearing AP, weight-bearing lateral, an infrapatellar, or what people will term the sunrise or merchant views, and then a weight-bearing PA 30-degree flexed. So people call that often the Rosenberg view.
Yes,
but
sir.
Basically, the patient bears weight, flexes their knee 30 degrees, and then it's a PA view. And that view is actually the best in the knee for the most common OCD lesions, because most of the time the OCD lesions that you're going to find in the knee are going to be on one of the condyles, like I said. And the most common location for an OCD lesion is typically kind of the lateral aspect of the medial femoral condyle. So if you're looking again at that weight-bearing flexed view, that's where you're really going to see that OCD lesion on the lateral portion of the medial femoral condyle, because oftentimes it's a little bit posterior too. And so that flexed view is really important, especially if you're thinking in your mind that this patient might have an OCD lesion and you want to get a really good visualization of that OCD lesion just with your initial imaging in clinic with radiography with x-rays.
So at what point do you move to switch on the MRIs, right? So if we get an x-ray and we see, for example, in the knee that we have a defect in the medial femoral condyle, do you jump to an MRI, or do you undergo some like non-operative treatment first? And if it doesn't get better, then jump to an MRI? Like in what case are you doing that?
That's a great question. And so that's where it gets back to your history and physical exam, as you guys had a great question earlier. And so a lot of times it depends on the patient age and then correlating with their history and physical exam. So if a patient is younger and then you see on their x-rays that they're skeletally immature, so their physes are still open and they just have a moderate amount of pain, then that patient is often initially treated non-operatively. And so non-operative management consists of kind of the usual anti-inflammatories, maybe some physical therapy, and in this case, typically some sort of activity modification where you definitely take them out of sports if they're doing that, and then oftentimes restrict their weight bearing to some degree with partial weight bearing or even toe touch weight bearing for a period of time on crutches. In the olden days, we used to actually, in the younger kids, we used to actually even put them in full leg casts, because nobody trusted young kids to not walk on their legs unless you put them in a cast, and that was
Still
kind of
don't.
yeah, right. And so we don't often do that as much anymore, put them in full leg casts for OCD, because a lot of the literature shows even if you just try and keep them off it or keep them out of sports as much as you can, and their physes are open, they'll still probably heal in the majority of cases. So we don't do that quite as often as we used to, but anyway, so that's kind of the initial treatment in that particular patient. And the patient that you gave the case example at the beginning, an 18-year-old male football player, highly likely that his growth plates, his physes are going to be closed. And he's had 4 months of pain and swelling. And so that patient is, you're probably going to see, if it's an OCD, which is what we're talking about, you see that on x-ray, it's a high likelihood you're going to then go to an MRI in that patient, because his physes are closed. And even if you do non-operative management for a period of time, you kind of want to characterize that lesion pretty well, especially if he's, like in the example given, if he's in like his senior year, or or if he wants to continue playing football, you want to have a pretty good characterization of what that lesion looks like on MRI, so that you can counsel that patient accordingly if non-surgical management may be an option for him, or if he may end up needing something further down the
line. Right. And I know we're talking about the knee, but what are some and I think you touched on the fact that some of the most common areas for these lesions are going to be on the medial femoral condyle, on the lateral aspect of it. But just to quickly touch on elbow and ankle, what are the most common areas for a lesion in those areas of the body?
Sure. So elbow is most commonly in the capitellum. And so a lot of times kind of like that lateral kind of aspect of the capitellum. And again, most commonly we'll see that present in gymnasts. Doesn't have to be a gymnast certainly, but most commonly in gymnasts, just because they're weight bearing on their elbows. And then in the ankle is most frequently the medial talus, and it's kind of the central to sometimes central to posterior aspect of the medial talus. And you guys made a great point that oftentimes we see that just in traumatic patients as well as in, kind of the congenital or type of setting. And so those are the most common locations in those two most common other joints. The knee tends to be where we see the biggest lesions, not only because the articular cartilage in the articular surface is the largest, so there's a larger area for it to encompass, but it also tends to be where you see kind of some of the bigger defects and bigger lesions as well. And so the knee, depending again on the type, exact patient history and physical examination and radiographic findings, the knee sometimes tends to be less amenable to non-surgical management, at least especially as compared to the elbow, because again, unless they're a gymnast, the elbow is a non-weight bearing joint. And so that's often very amenable to, or more so amenable to non-surgical conservative management, which we discussed earlier. The ankle kind of just, again, depends on kind of their activity level and the lesion characteristics itself.
Okay. And so we're going back to, some of the imaging as far as when we're looking at the MRI, and I guess we can go back towards the knee case that we had earlier. What are some of the things that we're looking for on the MRI, and what kind of helps you determine about stability of the lesion?
Yeah, great question. So that's a huge thing, as you stated. So is it a stable versus an unstable lesion? And so the stable lesion is one where there's not going to be a significant amount of subchondral edema, or in some cases even fluid beneath the articular surface or beneath the subchondral portion of the fragment of the OCD fragment. If you start to see pretty well circumscribed area below the defect, or even in the buzzword that they often say on the boards or say on the OIT and stuff is fragmentation. If it's a fragmented defect or fragmented lesion, which sometimes you can see on x-ray, but sometimes not. More frequently, you can see it better on MRI. Is fragmentation of the lesion. Then you start to worry that it could be more unstable. And then certainly in some cases, you can actually see a lesion become an actual flap or become loose or free floating, which is straightforward then, of course.
Right. So again, just to summarize that, so you said for our unstable lesions, those are the lesions like on MRI, you may see fluid that goes underneath that lesion. If it may be fragmented, or if you see a flap. And I know you mentioned a little bit earlier about the fact that our patient whose physes may be closed because he's 18. What does that have to do regarding, like, what role does that play regarding stable versus non-stable lesions if the physes is open or closed?
Yeah, just more commonly, if the physis is open, it's going to be more of a stable lesion more frequently. It's not going to have detached, or it's not going to be fragmented as much if they're still going through periods of growth with an open physis, and then more commonly it'll be classified, or it'll appear on your imaging as an unstable lesion if they have closed physes.
Right. Okay. And I think you spoke about it a little bit earlier, but so for our stable lesions at first, you were saying that we're going to treat those non-operatively, and that's where you're saying we'd be doing things like, activity modification, taking them out of any sports for a little period of time, NSAIDs, and then eventually going on a physical therapy. Um, I think we spoke about it. Do you repeat, like, for example, if the patients are getting better with your treatment, do you repeat MRIs to keep an eye on the lesion over time, or do you just go clinically, like if they're feeling better, you don't repeat anything else after they've done their period of non-operative treatment?